Good afternoon, and welcome to today's live congressional briefing entitled Myopia, a Public Health Crisis. I am James Cherkasky, Executive Director of the Alliance for Eye and Vision Research, or AVER, a 501c3 foundation that educates about the value of vision research. In fact, this is AVER's 7th virtual congressional briefing held since the pandemic began. This global briefing, under the auspices of AVER's research-saving site, Restoring Vision Initiative, is being held in conjunction with AVER member organizations, the American Academy of Ophthalmology, the American Optometric Association, the American Association for Pediatric Ophthalmology and Strabismus, Research to Prevent Blindness, and the Association for Research in Vision and Ophthalmology, or ARVO, which is providing today's live streaming support in partnership with AVER. I also wish to acknowledge Novartis for its event management support. Since ARVO is providing today's streaming, I'd like to ask ARVO's Laura Lanford to briefly discuss how participants can get the most out of today's briefing. Laura?
Thank you for the introduction, Jim. In advance of today's program, I would like to go over a few housekeeping items. This briefing is set up as a Zoom webinar and not a Zoom meeting, which means that only our speakers can turn on their video cameras and communicate verbally to the group. For participants, all communications should be directed to the speakers via the Q&A and chat features. Please use the Q&A box at the bottom of the screen in order to type your questions to the speakers. Please only use the chat box for other communications, such as letting us know of any technical issues or providing other comments that are not questions. Time permitting, all questions will be addressed during the Q&A portion of the briefing after the presentations at the end of the program. As a reminder, a video recording of the briefing will be available on the ARVO YouTube channel within 2 business days of the live event. A link to the event page with the video recording will be sent in a follow-up email. I will now turn it back to Jim. I hope you enjoy the program.
Thanks, Laura. Today's briefing features presentations by 2 expert clinicians who treat myopia patients on a daily basis. Jason Compton, OD, owns a private practice, Compton Eye Associates, in the New York City area. He serves as assistant adjunct faculty for the SUNY State College of Optometry, and from 2020 to 2021, he served as chair of the American Optometric Association's Contact Lens and Cornea Section. Catherine Lee, MD, PhD, practices at St. Luke's Children's Ophthalmology, a hospital-based multi-specialty pediatric clinic in Boise, Idaho. She currently serves as president of the American Association for Pediatric Ophthalmology and Strabismus, or APOS, and is active in clinical research through the Pediatric Eye Disease Investigator Group, which was formed in 1997 with support from the National Eye Institute within the National Institutes of Health. The National Eye Institute funds all aspects of refractive error research, including myopia. And I'd just like to note that AVER and its affiliate NAVER serve jointly as the privately funded Friends of the National Eye Institute. So our speakers today are going to tag team in providing formal comments, and they will magically appear live to participate in a dynamic Q&A session. So without further ado, Dr. Lee.
Thank you so much. It's really a pleasure to participate in this briefing. I'm going to kick it off by just explaining a little bit about what myopia is. You know, a good way to think of the eyeball is to compare it to a camera. So the front part of the eye focuses the light, and the light rays are directed to a pinpoint on the retina called the fovea. The retina is very much like the film in the camera. It takes the picture and sends it to the brain. In nearsightedness, the optics are such that the image is focused anterior to the retina. Therefore, the retina gets a blurred image. Correction of myopia with glasses refocuses the rays on the fovea and gives the image clarity. One thing that's really interesting about eye growth is that it is regulated by visual input. We know from animal studies that light intensity and image clarity affect eye growth. Signals to the cells in the retina direct growth of the posterior part of the eye. As eyes become more nearsighted, they become longer. The posterior wall thins and the eye becomes longer and nearsightedness increases. You know, an easy way to think about the difficulties that occur in nearsightedness is that as the eye becomes longer, there's just not enough retina to go around. On the left side of this photo, we see a normal retina. You can see that the color is very homogeneous. The FOV is the fovea. That's the spot where those rays are directed by the anterior part of the eye. On the right side, we see degenerative myopia. And you can see a lot of extra blood vessels there. Those are blood vessels that are deep to the retina, and we can see them because the retina has thinned, because there's not enough retina to cover the entire surface of the inside of the eye. We can also see that the optic nerve, shown by ON here, is tilted, and there's some pigmentary changes in the retina. Some of the eye problems that occur in all levels of nearsightedness include retinal atrophy. Those white spots that you see on the left side of this photograph are areas where the retina has simply dropped out because it's been too thin. Glaucoma is an increased risk in persons with nearsightedness. Sometimes there are new blood vessels that grow underneath the retina. And if you think of the retina as the film, this really is a problem for vision because those blood vessels put fluid into the retina and it does not take a very clear picture. Finally, there's a 3 to 12 fold increased risk of retinal detachment. You know, the problems with nearsightedness occur primarily in adulthood, but the eye is growing during childhood. So myopic progression is really a childhood phenomenon. When babies are born, they're slightly farsighted. This is a positive refractive error. As they become older, the eye grows and there's a shift from farsightedness to nearsightedness. The eye growth is very much like progression along a number line, which is why I've included the number line on this slide. The myopic shift starts primarily when kids begin school. The average progression of nearsightedness is about a half diopter per year. About 50% of children are done increasing with their nearsightedness by age 15. We define high myopia as being more nearsighted than approximately -5 or -6. Although it's our high myopes that tend to have the most difficulty with their nearsightedness, the problems that I showed can occur at all levels of nearsightedness. So nearsightedness needs to be slowed in childhood. Once you're nearsighted and your eye is long, we don't have any way to make it shorter again.
Thank you, Dr. Lee. I'm going to pick up from here. So Dr. Lee did an excellent job pretty much of detailing what's happening to the child, or I should say specifically the individual. This is serious stuff that we're talking about. We're talking about the increased risk of blindness, glaucoma, these blood vessels that she's talking about. But it takes us to a whole new level when we start to understand how serious these things are, but yet how many people are potentially affected by these serious issues. Let's talk prevalence. We can go to the next slide. I don't have any disclosures to show. So when we're talking about prevalence, we're thinking about like how big of an impact this is happening in our communities. And from a global perspective, if we look in the last 20 years, the prevalence of myopia has increased dramatically. Now, if we're going to dial this down even to the United States and we look at certain demographics, say age 12 to 54, We look at that demographic in the, say, the 70s, about 25% of people in this demographic had myopia. We look about now, that number is almost doubled. So we can see how this is an exponentially growth of a problem. Now, studies show variations in prevalence of high myopia and myopia between different regions and ethnic groups. But what I really want you to focus in on is this image that I have right here. You see what it says here? It's actually projected that half of the world will be myopic by 2050. Now, I really want you to understand the impact of what that really means. And the way to understand the impact is really just going back to what Dr. Lee said. Understand that 50% of the world's population will be at a greater risk of blindness. 50% of the world's population will be at greater risk of glaucoma, retinal detachments. 50% is a big number, and these are very serious concerns. You know, when we think about the pandemic, which we're currently still going through, offices like my own saw this on a whole different level. Think about it. Children were forced to do remote learning. So what did that mean? They had increased screen time, hours and hours in front of a computer. Now, that had a direct impact on the conversation that we're having today. Valid concerns have been raised about how aggressively myopia has grown or progressed during this time. And this is actually being studied today. Studies is really what this all boils down to. Studies is really why we're talking to you all today. Because when you understand the dramatic increases in numbers that we're seeing, when you understand the changes in society as we've seen with COVID, you can begin to understand why doctors and scientists really need to do more research, more studies to help understand this better. Dr. Lee's going to talk a little bit more about the research.
Thank you, Dr. Compton. I'd like to start off by talking about some genetic and environmental considerations in myopic progression. You know, it's long been observed that educated urban dwellers are often myopic, and much of the research has been directed towards the influence of those environmental factors. We also know that animal models show that eye growth can be modulated by visual stimuli. So what about genetics and nearsightedness? You know, it's actually not a huge contributor. There are 600 genes that are associated with nearsightedness. A child's at increased risk for developing nearsightedness if one or both parents are nearsighted. But the increased prevalence in nearsightedness that we're seeing cannot be strictly genetically based because it's just increasing too rapidly. So there are significant environmental influences that come into play, and one is outdoor exposure. We know from animal models that light exposure slows nearsightedness. We know that nearsightedness tends to progress more quickly in those dark winter months. Clinical trials have shown that increased outdoor exposure can delay the onset of nearsightedness in children. And this is significant because if a child has less time to become nearsighted, they're less likely to develop a high level of nearsightedness. We have also learned recently that bright indoor light can be a substitute for outdoor exposure. Dopamine is a molecule that's thought to mediate the retinal signaling of outdoor light exposure. The next thing is near work and myopia. You know, this has sure received a lot of attention during the pandemic, but you know, as I said, we've long known that persons who are readers tend to develop nearsightedness. But I want to direct your attention to the left side of this slide, and there has been a fascinating study that's come out of China that helps to demonstrate the influence of the recent pandemic on nearsightedness progression. So to orient you, this is a longitudinal study along the x-axis here. In China, they measure the power of the eye for each child entering school. And each of these graphs shows a different age of the children. So we know that China entered an early and aggressive lockdown in the pandemic, and we can see that the level of nearsightedness demonstrated by children took a huge increase in particularly the younger children in ages 6, 7, and 8 between 2019 and 2020. We have to really reason that this has to do with the intensive near work that was associated with virtual learning. We've done several studies regarding reading and nearsightedness, and we've shown the following. A reading distance of less than 8 inches is correlated with an increase in myopia progression. A sustained reading effort and a high volume of reading are also correlated. And there's some evidence that black on white print can be contributory. So, people ask Dr. Compton and I all the time, what about that phone? Well, it stands to reason that use of electronic devices is associated with myopic progression. But we need to remember that nearsightedness was progressing well before we were all using digital devices. The scientific evidence regarding phone use and myopia progression has not definitively shown that use of the phone is correlated with nearsightedness progression. But honestly, I think we just need more research, and that will be demonstrated. So the recommendations we make to our families regarding lifestyle changes to slow the progression of nearsightedness involve taking breaks when reading. And I really like this 20-20-20 rule. Every 20 minutes when a child is reading, they should take a break for 20 seconds and look at a distance for 20 feet. We also encourage a reading distance of greater than 8 inches and at least an hour a day of outdoor sunlight exposure.
So at this point, I really want to talk to you about other forms of treatment, or what we're doing to kind of battle myopia. I have listed here some of the ways that we currently address myopia, and I'm sure you're familiar with those, be it soft contact lenses, we have rigid lenses, scleral lenses, you can use glasses, you can do different types of surgery. Now, while all these things are great because they help us see better, the traditional methods, they don't do anything to address the progression of myopia. And that's really where the real problem is, because we want to slow this down. But fortunately, we do have options. Try the next slide. When we talk about interventions to slow the progression of myopia, we have soft multifocal lenses. We have something called orthokeratology. We have spectacle lenses, and we have atropine. So what Dr. Lee and I are going to do right now is just kind of educate you all on the different methods that we have at our disposal to control this myopia. Now, what I want to do is I want to revisit something that Dr. Lee touched on in the beginning of her slides. And it's going to help me explain how our treatment works. Now, I want to give you an analogy. Forget about the eye for a second. I want you to think about a movie projector screen. You go to the movie and the projector focuses light on a screen, right? Now, that screen is flat. If the image were tilted, if that projector screen were tilted, what would happen to that image? As you can see in the bottom, maybe the top part of that image would be blurry, the bottom would be clear. Why is that? Because the projector is focusing at a specific distance. Got that? Now let's translate that into what's happening into the eye, because something very similar is happening. The back of the eye, where the light is focused, is not flat. It's curved. It's an eyeball. Now, while our central vision gets that nice clear image, which is depicted with those black lines, you notice where the red and the blue are? Those images are blurry. Now, in an adult, that's fine. But the child's brain does not like that blurred image, those red and blue lines. So what does the child's eye do? The child's eye begins to grow. In an effort to clear up that red and blue, what we call the peripheral image, the eye grows longer. Now, once the eye grows longer, now those red and blue lines, that side vision is clear. But what happened? That central vision, which is most important, is now blurry. So little Johnny goes to mommy and says, I can't see through my glasses. The doctor increases the prescription. We get clear vision, but then we have the blurred sides again, and the eye grows. It's a vicious cycle. The doctor increases the prescription, the eye grows, we have to update the glasses again. It's a vicious cycle that's going on that's actually causing the myopia to increase. So in order to fix this problem, we need a form of correction that will allow the middle portion to be clear, but also the peripheral portions to be clear. Fortunately, we have those options. Soft lenses for multifocals are contact lenses where the middle portion has a certain prescription, the outer portion has a different prescription. Again, enabling us to be clear in the middle, clear on the edges. Orthokeratology is another example where we're actually reshaping the front of the eye so that child can have clear vision in the middle, clear vision on the edges. Again, telling the eye, don't grow, do not elongate, do not increase myopia. There's some methods of slowing progression with glasses. We don't use these currently in the office, but some of the recent studies are promising. But we also have something called atropine, and for that, I'm going to turn it over to Dr. Lee.
Thank you, Dr. Compton. Oh, let me go back one. I want to let you know a little bit about an exciting use of an eye drop that we've had in ophthalmology and optometry for years and years and years that can help slow the progression of nearsightedness. Now, this is a very busy slide, but I'm going to walk you through it because it has some really important information. So this study was done in Singapore, where children have a very high level of nearsightedness progression. Now, we know that reading efforts can cause increased nearsightedness. So we used a dilating eye drop that dilates the eyes and also reduces the ability to make a focusing effort at near. If you direct your attention to the triangles, we can see that this drop at a 1% concentration slows progression of nearsightedness over the 24 months that it was utilized. This spherical equivalent is our measure of nearsightedness, and as you go down this way, you're becoming more nearsighted. If we compare the children who were using this drop to those who weren't, shown in the orange triangles, you can see that while the children were using the eye drop, their nearsightedness essentially was absolutely stable. Unfortunately, at this concentration, this drop has a lot of side effects, including blur looking up close and pupil dilation, which gives a lot of light sensitivity. In addition, when the drop was stopped at 24 months, there was a rebound catch-up in nearsightedness. So at the end of the day, it didn't really have a sustained effect once it was stopped. What I'd like you to look at now is these green circles. So using that information, the next study that was done by this group evaluated lower concentrations of atropine. And lo and behold, the lowest concentration, 1/100th of that 1% concentration, was the winner. While the children were using this eye drop, it had good efficacy in slowing the progression of nearsightedness. More importantly, when they stopped, this effect was sustained. The drop was restarted and continued to have good efficacy. So at the end of the day, this drop slowed the progression of nearsightedness by 50%, which is significant. In addition, the side effect profile of this drop was minimal blur at near, minimal dilation, very well tolerated. This was definitely a win for children with nearsightedness. There have been additional studies, and this study comes from a group in Taiwan, and it is ongoing. They've investigated 3 low concentrations of atropine, and we're seeing that a slightly higher concentration, that 0.5%, might be more effective. Another thing that's coming from this study is that the group that is progressing the most in nearsightedness progression are actually the younger children, those 5, 6, 7, and 8-year-olds. You know, it's really my pleasure to be an investigator in a US trial regarding low dose atropine. This is funded by the National Eye Institute, and I'm an investigator through the Pediatric Eye Disease Investigator Group. In this study, we are enrolling children between 5 and 12 years of age with the level of nearsightedness shown. It's a 2-to-1 blinded randomization comparing low-dose atropine to a placebo. The children are on treatment for 2 years and then off for 6 months. All participants and all investigators are masked. Our goal is to determine the efficacy of this drop on treatment in slowing nearsightedness progression. A secondary outcome is to see what happens with nearsightedness in the 6 months after the drop is stopped. We started enrollment for this study in June of 2018, and I'm excited because our primary outcome data will start to be robust and full, where we can start to look at it next spring and summer. So how are clinicians in the United States using low-dose atropine? Well, the efficacy in Asian children has been really compelling, and we have that low side effect profile. So honestly, it's been widely adopted in the US, even though studies are currently ongoing to see how well it works in US children. Unfortunately, at this point, however, it's not FDA approved. So the use is off-label, it's compounded, and it can be expensive for families. And there are many questions that still remain regarding the best use of low-dose atropine.
So what it basically all comes down to is that we can all play an active role. What we really wanted to do with this forum today was educate you not only on the risks associated with myopia, but what is actually being done to kind of solve this problem, but also on the same token, educate you into the idea that we need help, we need assistance, because preventing myopia is something that's going to have a huge impact on the patient's lives. We think about a quality of life issue, but there's also the fiscal responsibility when we're talking about elected officials and the long-term benefits to our healthcare system if we can slow this down so we don't have to worry about patients having problems when they're older. What's going to help that? Ongoing research and additional information. Both optometrists and ophthalmologists are ready and willing to help to do whatever we can to address this epidemic of what we call myopia. Thank you.
Thank you, Dr. Compton. And now we're going to go live with our faces here. Dr. Compton, thank you for that very hopeful slide. And I want to point out to everybody that that's your lovely daughter with you.
Yeah.
Showing the hope, looking into the future. Okay, we have quite a few questions that were submitted with the registration, and I've organized those. And I'd like to make just one note as we begin this dynamic Q&A, and that is that this discussion may get into a broad range of policy topics that are really outside the realm of AVER's research mission, but we feel it's important to identify these for all to be aware and to potentially address through policy. So for both of our speakers, and we're trying to get it really, helpful information here. What is the one thing that you wish that parents or caregivers knew about myopia? And are there no-cost steps parents and caregivers can take to help children? Dr. Lee, let's start with you.
Well, first of all, I'd like to reassure parents that we can correct your children's nearsightedness with glasses and contact lenses. We can give them good clarity of vision. But what I'd like them to be aware of is that if they have a young child, 5, 6, 7, 8, whose nearsightedness is showing progression, that's concerning. That's a child who's going to end up being significantly nearsighted. And we do have means to slow the progression of nearsightedness at this point.
I would add to that there's also hope that we're offering, because I can't tell you how many patients come to my practice and it's just mom or dad, they don't know what to do, because every 6 months, every year, the prescription is getting higher and higher, and their doctors are not offering anything other than new glasses. So the idea, I really want parents to understand that options do exist and we can help to kind of address the concern that they have, even though they don't have a background in this field.
Thank you. This question is one of my favorites. I've been called an aging myope by my eye care professional. So the question is, we've talked a lot about younger patients so far, but can you talk to us about the longer term health risks that exist for individuals with myopia? Dr. Lee?
Well, I touched on this in my presentation. The most of the risks have to do with thinning and degeneration of the retina, which can occur. It can atrophy, it can get wrinkled, it can come away from the wall of the eye. The vision loss that occurs with those problems can be permanent, and that is really a major concern. And those problems occur at all levels of nearsightedness. So no nearsighted person is free of risk for retinal problems.
And that's why we take this so seriously for younger children, because there are studies that show once your prescription is over four diopters, that your risk is almost tenfold, where you have risk of what we call myopic retinopathy. So addressing these problems early really severely reduce risk of problems when we get older.
Great. I have sort of a compound question here. And Dr. Compton, you alluded to some of the impact of COVID. So first of all, I'd like each of you to talk a little bit about how COVID affected your actual practice, loss of patient to follow-up, et cetera. And then I know each of you talked about it a little bit, but I want to impress upon our viewers today the whole issue of increased screen time, increased phone screen time, sitting too close to the television, all these kinds of things. And what do we know about the impact of any of those on myopia? So Dr. Compton, let's start with you. You spoke a little bit about COVID.
Yeah. So, anecdotally, and I say anecdotally because this is something that's actually actively being studied right now, we definitely saw increases of myopia during the pandemic. And as I alluded to during the slides, it's because these kids are spending so much time in front of the computers or that screen time. We look at other effects of it. We saw an increase of dry eye. We have things like accommodative spasms where the children weren't focusing well. If you think about your eyes are designed to look far, okay? Yes, they help us read up close, but our eyes were never designed to spend hours upon hours focusing at this distance. So our whole society is changing because of this, but it's definitely having a huge impact on our kids.
Yeah, I definitely agree with that. I think the pivot to digital devices that has occurred in the pandemic for all of us is not going to go away. And we know that, sustained near work causes myopia progression. So it certainly stands to reason that our increased sustained near work that we're all participating in as a result of the pandemic is going to continue to boost the increased prevalence of nearsightedness.
And just one short commercial message. In July, we had an AVA briefing on dry eye, and Dr. Jennifer Craig from New Zealand spoke at length about the impact and the studies they're doing on increased screen time on children in dry eye. So you can go to the AVA website to watch that briefing, which was recorded. Okay, I'd like to move on to another question here, and that is, can you expand upon the dual issues of health disparities and access to care for individuals with myopia? A really important question. Dr. Compton.
Well, access to care, a very important question. The problem I have with this is that it's so easy for us to detect this. It's so easy for us to provide options for patients, but if they don't have access to doctors, if they don't have access to the equipment necessary to do this, it becomes a huge issue. And I think it becomes a demographic issue. It becomes where these patients are located. It doesn't require expensive equipment or extensive training to be able to do the kind of stuff that Dr. Lee and I are performing for our patients, but access is a huge issue.
Yeah, I agree with that. For some families, just access to correction of nearsightedness is a problem. They can't afford glasses, and they can't correct the nearsightedness. Add on top of that difficulties with accessing these more expensive treatments of nearsightedness, and it's a real problem.
Great, thank you. And related to that, although numerous studies have estimated that although myopia and other refractive errors represent a significant portion of the cost of vision impairment, they also acknowledged it as what I call low-hanging fruit. That is, in terms of actions, simple actions that could be taken to prevent or reduce these costs. Could you comment a little bit about what those steps might be, sort of how we can deal with this issue, although expensive, particularly fixable with solutions? Dr. Compton?
So you're referencing that's the cost of treatment for patients that fall into this category?
Yeah, a prevent blindness study from 2013 extrapolated to 2021 showed that refractive errors, including myopia, have the highest, represent the highest cost among all the vision conditions, about 18.2 billion of the 177 billion annual cost. But also the September 2016 National Academies of Sciences, Engineering, and Medicine study highlighted that there could be significant cost savings, savings upwards of 40-fold if refractive errors are treated properly. So any thoughts on that?
Absolutely. I mean, I think that it goes to education of the public, educating the public that detecting these problems early enough. I know ophthalmology is, and I can speak personally for our organization, the American Optometric Association. We try very hard as far as advocating and educating the public of the importance of early eye exams, more than just vision screenings, because this, again, if we address it early enough, it has a huge financial impact on our healthcare system, because as we've explained later on in life, you can put yourself at risk for a whole host of problems that could have been avoided if this was addressed early enough.
Dr. Lee?
I guess I would just add to that there are those things that families can do for free, whether they have nearsighted children or not. And those are all great health options, including spending at least an hour outdoors every day and taking breaks while doing sustained near work. If we can slow the onset of nearsightedness by a year for every child in America, that is a huge, huge public health savings.
And let's get back to a scientific question again. So the scientific as well as the popular press have published articles which have emphasized the importance of children getting outside and playing as a means to potentially avoid myopia onset of progression. I believe, Dr. Lee, you had this in your PowerPoint. I'd like to get into that a little bit more. And also we have a question here. Dr. Lee, can you provide studies supporting the role of bright indoor light to be as effective as outdoor light for eye development?
Those studies are more recent, and there's a certain number of lumens that are associated with outdoor light exposure, and that level of light intensity can be duplicated by indoor illumination. And some recent studies have shown that changing the light indoors may be as protective as an hour of outdoor light exposure. Those results are rather preliminary, and I think we need more information. And I look forward to that, because if we, it's a great idea for kids to go outdoors and play for an hour. Don't get me wrong, but if in addition to that, we could do something with indoor illumination in educational settings, for example, that might also have increased benefit.
Dr. Compton?
I think this speaks to how addressing myopia is a multifactorial approach. I mean, there are genetic components, there's ethnicity components. We talk about outdoor light. We talked about the treatments that we offer in our offices. Being able to hit this from different sides really helps our patients, even for those, as Dr. Lee mentioned, if there are financial concerns, there's things that patients can do today that are free, no cost. And the studies are proving that these methods are reliable.
So we've actually received several questions live, as well as my prior questions here. Our audience is interested in how you treat your myopia patients. Could each of you kind of walk through, let's say the child is coming into your office, kind of walk us through what you do with that myopia patient and how you then determine what would be a course of treatment. Dr. Compton.
A huge portion of it is understanding family history. So when I have a new patient, I really want to understand mom and dad's refractive error, because as we spoke, there is a genetic component to this. If we see a child has a certain refractive error that puts them at risk, if it's the first time we're seeing them, they're not wearing glasses, we'll give them the glasses and we'll track them over a period of time. There's something that we call an axial length measurement that we take. If you remember, both Dr. Lee and I spoke about how the eye is growing longer. That growing longer is really where the myopia increase is coming from. So we have devices in the office to measure that. Then we'll have the child back in a couple months just to kind of see where the progression lies. And then as we outline, or as I outlined in my slides, we have different options to offer the patients. Some are pharmaceutical, some involve contact lenses, but it's great to be able to offer patients the options, but it's even better just to be able to educate mom and dad about what's going on. And it really does require education, because if you think about it, mom's just coming in to get a new pair of glasses, and all of a sudden I'm talking about eye drops and treatment and risk factors when the child is 15 and 20 years old. So you really have to take time to educate your patients. And in our office, we have a pretty good system in place where we can do that for our patients.
Dr. Lee.
I agree with everything Dr. Compton said. It used to be that the nearsighted kids were our easy visits. Here, have a pair of glasses. Oh, and they loved it. Their vision's clear. They're like super excited. Well, now it's much more of a conversation. And I do, all those things Dr. Compton was referencing. One thing I do want to point out, though, is that I push a little harder on those younger kids who are showing levels of nearsightedness or are showing myopic progression, because they have the greatest room to grow in the progression of their nearsightedness. They're the ones that I'm most worried about becoming high myopes, crossing that threshold of -5 or -6, where the risk of complications is that much higher.
Thank you. Although AVER doesn't really deal with these issues, I do think it's important that we kind of look broadly. And one of the questions we've received is, can you discuss what efforts are being done in your organizations to make myopia management treatments considered medically necessary so that insurance will cover services? And it kind of gets to the access issue and some of the things we talked about earlier. Dr. Compton.
So I think it comes down to education. It's basically why we're sitting here right now in front of our legislators and decision makers. And while I don't try to get involved in that aspect of it as a clinician, again, going back to the educational piece, we have to educate the parents, but we have to also educate our legislators and have them understand the impact and actually the fiscal responsibility of not addressing this in the appropriate way.
Dr. Lee.
You know, the way we've sort of sliced up the body in healthcare, you know, we sort of removed the eyes and that's vision care,
Yeah.
and we removed the teeth and that's dental care. But, you know, we're here to educate you that, you know, a simple refractive problem, nearsightedness, has medical consequences. And so, you know, it's something that needs to be addressed. This is a huge societal issue.
And as an aging myope, I can tell you that my eye care professional told me that my posterior vitreal detachments resulting in major floaters in my eyes are a result of being an aging myope. And, you know, I will say that one of the most frequently asked questions I get at AVER is, what are floaters? Why do they occur? And what can be done about them? Okay, I want to get a little more philosophical here and ask you this question. What is the one thing that each of us can do tomorrow to protect our own sight or the sight of those we love starting today? Dr. Compton.
I think one of Dr. Lee's slides, one of her slides spoke to it best. Simple, the 20-20-20 rule. If you are a person that spends an extended period of time on the computer, this is not only for kids, even adults. Every 20 minutes, take 20 seconds to look at something that's 20 feet away. Look out of a window. Look down the hall. Remember what I had said earlier. Your eyes are designed to look far all day long. And if you're focused here all day long, you're working that visual system in ways that it just wasn't designed to do. So to relax the eyes, look at something far, it's cheap, and it can be done very simply.
Dr. Lee.
You know, I would certainly endorse that as well. But I want to just take it to just maybe a little bit more global level. And that is that, you know, with this pandemic, we're 18 months in, have all missed a lot of routine medical, dental, and vision care. And, you know, we have protocols in our offices to make children and families safe when they come to see us. So it's time to get back to the pediatrician. It's time to get back to your eye care professional. It's time to get back to the dentist. You know, that preventative care, you know, helps the eyes, helps the body, helps everything. And we need to get back on schedule for that.
Excellent. Well said.
And a question has come in, again, getting back to the practice. What are the criteria in the age 5 to 10-year-old age group that provide clarity for the more modern treatments beyond standard glasses? Or in other words, what level of progression in between visits is necessary for these new treatments? I think that's an excellent question. Dr. Compton.
I think it's dependent on the child and of the situation. As I said, if I have a child that's age 5, 6, and I know mom is a -10 and dad is like, you know, a -8, I know where that child is going. You know, I know what the future holds for that child. So I may be a little bit more aggressive with that child than a child that maybe doesn't spend as much time on the computer or doesn't have that genetic component. But it is case specific. When we talk about FDA approved options, you know, some of the options don't really indicate an age. You know, we talk about orthokeratology, we talk about contact lens treatments. The FDA has been very helpful as of recent in improving some options for these children, and we want to continue to encourage that.
Dr. Lee.
You know, myopia treatment is something that is highly individualized, and I think it's going to become more so as we get more information. You know, we're starting to learn to be more worried about the younger myopes. Dr. Compton mentioned genetics, and certainly I too am more concerned about, the child of the -8 parent and the -10 parent. And a lot of times those parents are a lot more concerned too.
Yeah.
So that is a driver of treatment. So there's no cut and dried rule for when to start treatment, what level of progression you should be aiming for. So it is highly individualized.
Thank you. And we'll conclude with a final question. And I always like these briefings to end on a very hopeful note. So my question to each of you is, you both care for children and aging myopes. Can you share one of the most gratifying moments you've experienced in caring for a child with myopia? Dr. Compton.
I wouldn't say it's one specific. It's just kind of the overall general feeling that I get from parents. The feeling that, they have possibly seen other practitioners that aren't offering myopia management, and to be able to offer them the ability to slow down what's going on. I mean, Dr. Lee and I and other practitioners, we understand what's going on, but what they see is every year they got to come and buy new glasses. The insurance only covers glasses once every 2 years, and they're frustrated. They don't mind spending the money for new glasses, but they just want to know, they want an answer. They want to understand what's going on. And to be able to provide that for a patient speaks volumes. And that's really what helps me get through it.
Dr. Lee.
Yeah, I certainly have that experience as well. And, there's no kick like giving a myopic child their first pair of glasses. But one of the things I want to highlight for this group is that, I'm involved in this nationally funded myopia trial. And we have about 20 kids at our site, and about a third of them have finished the trial. And these kids have done a great job. And it's so gratifying, that final visit, when, we give them a certificate of participation, and we eventually we unmask the child and the family, and show them what treatment group that they have been in. And they're just so excited to have this information. They're really excited to have participated in something that's bigger than themselves and that is going to move this area of research forward. So that to me has been a really gratifying experience as a clinician and a scientist.
And I appreciate you reiterating for the group about the importance of federally funded vision research. Obviously, I want everybody to know that the National Eye Institute has an excellent website, www.nei.gov, part of the National Institutes of Health. You can read about various vision conditions. You can read about clinical trials that are happening. You can also go to clinicaltrials.gov. I want to thank our speakers for today, Dr. Compton, Dr. Lee. It's been a pleasure working with you in every step of the way.
Thank you.
Thank you for being live and thriving. That concludes our briefing. I have a couple of housekeeping announcements, and maybe Laura can help me too. AVER wishes to thank our speakers and co-sponsors for this engagement in this important education. I also want to thank you, Laura Lanford from ARVO, in partnering with us to stream this live. Note that AVER will stream a World Keratoconus Day 2021, dealing with corneal issues, a briefing on Wednesday, November 10th at 12 noon Eastern. More information about this briefing can be found on the AVER website at www.iresearch.org on the bottom of your screen there. Thank you, everybody, for your attention today, and we really appreciate you participating. Thank you, Dr. Lee and Dr. Compton.